Okay, so next one, I'm going to talk to you a little bit about premium IOLs. So this is the Medicontur premium class. I think, just put my slides up, please. So I think you can either say you like or don't like the word premium. I think we use it a lot when we refer to these presbyopia correcting IOLs or toric IOLs or aspheric IOLs. And really, I think it's a double-edged sword when you decide to say it's premium, or do you want to call it advanced technology? Perhaps that's a better term. Because when you talk about premium, you're actually associating a higher value to it. And when you have higher value and you have higher expectations, and therefore you have to deliver. So what I'm going to talk about is why we should use these premium IOLs and how to actually use them, and of course, what are the prerequisites that at least us as surgeons, as doctors, what we need to do before we adopt this technology, and some principles and guidelines for success, looking at how to select patients preoperatively, intraoperatively, what we need to be able to be competently doing, of course, cataract surgery, and post-operative considerations as well. And really, I think during the Slido, we saw, how most of us would want to look at patients' lifestyle and expectations, and that's how we select the IOL for the patient. So what is a premium IOL? If you look at the definition of premium, you're talking about something where there is a higher than usual quality or value. And of course, the other thing about premium is something extra or an extra amount charged. I think that's quite a given now. We know that when you actually want a premium product, you would expect a premium price. I think it's something that is probably the law of nature. I think it's very unlikely that you want to have something very good and not have to pay a good dollar for it. But I think I'm Chinese myself. I think the Chinese always want a bargain, right? But sometimes in life, you cannot always get the best bargain. But I'd like to hopefully share with you some of the value that's associated with this, so it's not just about saving money. So in the IOL, it's something extra. And really the extra, I think I would like to class it this way, in the sense that it's not just presbyopia lenses. I think toric lenses should be considered premium because there's something that we have to do extra for the patient, and there's some prerequisites that we need to be able to do before adopting toric technology. I think Alison is going to talk about that. Asphericity, I think, has become almost a given to us. Perhaps it's not premium anymore, but there are still, I still use spherical lenses because it's an option for some of the patients which just want the most basic lens, and we still use spherical lenses. But aspheric lenses are technology that's not been that long around. It's been around long enough, and we almost think that it's become the standard, but it's not quite there. Now, presbyopia is really the holy grail of ophthalmology. I think us cataract surgeons will think that. And why? Because we're always looking for the next best thing to try and correct our patients and get rid of their glasses. So we're still looking for it. Now, some of these surveys, this is one that's quite old, but ASDRS, the American Society, will always have surveys sent out to their members. And this is just something from 7 years ago. So it's not the same question every year, but we're trying to show the current level of adopting, the level of people adopting this kind of technology. And you see, even in the US, there's a lot of people that's not really taken up presbyopia IOLs. It's about 10%. And similarly, in Europe, again, the numbers are not high. We're talking about 10, 15%, 10% perhaps. So this is as recent as 2022 and 2019. So you're looking at these numbers, it's not high numbers. But why is it that you're here at a premium class? Because you're trying to learn more about how to use these lenses. And why we are talking about these lenses more? Because there is a shift towards that. So you look at, most of the time, if you look at older surveys and you ask about them now, you find that more and more of us are moving towards in that direction. Not so much because we are trying to make sure that our patients pay more for what they want, but at the same time it's because there's a demand for it. Because most of us here, myself getting into the presbyopia age, find that reading glasses are really not very convenient, especially with our phones and our computers. So there is a demand for that, definitely. And as doctors, we just want to make our patients happy. So if there's a demand, and if you're in a setting where you're not able to give that to your patient, then you're perhaps losing out the patient to somebody else, and you're not growing your practice. So why the change? I think there's a high demand, active lifestyle, digital era, technological advancement. You don't have to elaborate too much. One thing I've noticed, I think, does anybody still remember what COVID was? It's been 5 years already, COVID has come and gone. But what I did notice, especially at least in my practice, after COVID, there was a definite increase in the demand for spectacle independence. Perhaps, when you had to wear masks with glasses, or, that just made it more inconvenient. Those of you that wear glasses and a mask, you find that, it fogs up sometimes. Now, from our perspective, we can also be patients, but from the surgeon's perspective, why do we want to change and move towards premium lenses? Because really, I think if we're trying to be the best doctor that we can, we always wanting to deliver the best to our patients. We're not just there to, just do a run-of-the-mill job, because we demand excellence of ourselves, and for that, we want to deliver what the patient wants. And when you do get very satisfied patients, which you can when you offer these lenses, your practice also grows. But again, there's no reward without risk. So I'm not saying it's a risky undertaking to take premium IOLs, but the stakes are higher. Why? Because your patients' expectations are higher, because you're trying to tell them that you're going to end up perhaps without glasses all the time, and you're going to have to charge them more. And so you have to be prepared to handle unhappy patients. So you cannot expect to try and run a premium IOL practice or a refractive cataract practice and not have an unhappy patient. Because when you do enough, just like when you do phaco, you do enough, you're going to have a rent one day. And you have a rent when you have to put in multifocal lens, then good luck. How do we manage that? But it will happen. But I'm not saying it's going to happen frequently, but you're going to have a patient sitting in front of you with that problem, and you've got to have to learn how to manage that. So currently in my practice, I think, actually Alison just asked me just now, I think when I first started, presbyopic correction was about 10% of my practice, and I think that should be. We always try to tread cautiously. But as you get better and as you learn more and more about how to actually use these lenses, and you get more options to use as well, I find that in my practice about half of my cataract patients are presbyopia correcting, and the other half will just make up monofocal torics or monofocals. So what are the prerequisites? I think for us, at least, we have to be motivated to actually deliver the latest technology. I think in ophthalmology, we are a specialty that really drives forward very quickly. Every year we hear about a new lens perhaps, or a new machine, and we have to be updated. I think that's why you're here as well, because we always want to be updated with the latest to deliver the best. Like I mentioned earlier, make sure you can deal with unhappy patients. They're not nice to deal with. We always have the patient that sees 6/6 and then they complain that they're blind and they can't see and you're wondering why, but you're going to have those. You're going to have to manage them. Now, we have to be at a level of surgical competency that you're not going to have many complications. You have to have a low level of complications before you want to really embark on this, because you do not want to have complication after complication whilst you're trying to use these lenses. So make sure that you're well trained that way. And your team has to be well trained as well, because as we know, when you run a practice, you're not a one-man show. The reception counter, your counselor, your nurse, your OR room, your OR nurse technicians, they're all important parts of the surgical wheel and the surgical team that we actually to deliver the best outcomes. Now, all these machines, or rather investing in technology, is another aspect that we have to look at, because again, you have to be prepared to put out the effort to gain the reward. So really, I think we have to invest in at least the optical biometer. I think I won't recommend doing any of these premium lenses if you do not have at least an optical biometer. And OCT, I think, is also crucial. Why? Because you have to make sure you exclude the patients which are not suitable, and that's a lot of the time when you find problems in the retina, you do not want to put these lenses in. Make sure you're aware of the latest IOL formula that you have. And earlier on, talking with Dr. Lin about the kind of different formulas we have now, and we should be using the latest generation ones. And the one that's really gained a lot of popularity in the last decade is the Barrett formula from our great colleague Graham Barrett from Australia. And plus minus a corneal topographer, I think if you have one, it's definitely an advantage. It's not absolutely necessary, I think, but some might argue that. I think my panel might argue that if you want to look at, spherical aberrations, or rather high-order aberrations, sometimes you need something more. Now, I like to simplify things. Just understand that really what you need to understand is when you want to know the technology. So that's why we had Thibaut here talking about the different IOL platforms, the optics. And then I don't pretend to understand exactly about the technology of the lenses that I use, but you have to have some understanding of how the lens works before you're going to start sticking them in into your patient's eyes, because it's important to know which patients are suitable. So you have to understand the other eye conditions that the patient may have, and most prominently I'll mention is dry eyes. So if you're going to be dealing with patients for premium lenses, you have to be able to manage dry eyes. Understand the patient's visual needs, so you have to spend time to sit down and ask the patients questions as to what their wants and needs are. Do they drive at night? You know, do they have a lot of reading? I mean, do they read just English text, or do they read, you know, in Asia we're quite diverse. There's Thai, you know, there's Chinese particularly. So there's a lot of different requirements that we have to think about, particularly in our population when it's a bit more diverse. And you have to understand your own outcomes. So you might be operating and you say, I do 1,000 cataracts a year, I don't have any complaints. But you think you don't have any complaints because when you have a complaining patient, you block it out. You don't want to think about it. So you just say, okay, I had a bad day, have a drink, forget about the patient. So we need to really audit our outcomes to actually know how we're doing. So unless you sit down and actually look at your outcomes, then you're going to know, okay, I need to tighten it here. Perhaps my PCR rates come up a little bit, or, you know, my refractive outcomes are a bit off. That's how you can actually fine-tune all these little things to make sure that you deliver the best outcomes for your patient. So there's so many options. I think each time you're going to add more and more to all these options available out there. So I didn't even get to put the EPS phase shift in here because this was done a couple of years back. But really, which IOL to offer, I think we have to decide on a few. We can't have a whole list of 20 and decide, okay, there are 20 different scenarios where I'll use this for that. So I think that's quite an individual thing for the surgeon. So we have to have a few favorites. For whatever reason, you have a favorite. It may be a Medicontur lens, and I think Medicontur would love for that to be the case. But at the same time, the principle of it is to understand the IOL and find which one is the best. And unfortunately, I think some of us are fortunate to have had the Elon available to us in Malaysia for a couple of years, whereas Taiwan is just getting it. So accessibility is one thing. It's not universally for all markets. So in Taiwan, if it's coming in now, I look forward to you guys trying it. I'm sure Medicontur look forward to you trying it. And you must look at the evidence that's available, and hopefully we can provide that for you about this latest technology. You know, it's sometimes not enough to say, oh, so-and-so put it in, so it must be good. So you have to be a little bit more inquisitive and find out a little bit more to make sure that it is indeed working. And it helps, of course, if there's a track record, if it's an established company, something like Medicontur has been around for years. They're doing a lot of good technology there. And of course, cost is always an issue to us, especially in the private sector. I think most of us here are in that. So sometimes that becomes a consideration as well. And don't forget the support you get from the actual people, in this case, a distributor, or in some direct markets, Medicontur's team can support. But most of us in this part of the world are dependent on the distributors. And if you have somebody that can support you well, it will, of course, make it easier for you to adopt this technology. So really, it's about matching the lens to the patient. So you have to choose your patients. I think there's so many good lenses out there. Having the individualization for the lens to the patient is really the key. And that is something that is developed with experience. It's a bit of an art, but it comes with trying to understand and spending some time, be it you doing it directly. Many of us have busy clinics, and whether you work that into your consultation with a patient, or you work it out into the flow whereby you extract this information that is present for you to actually look at when you start talking to the patient about lenses. So sometimes people use vision simulators. I don't have one, but there are some available online which you can use, or perhaps some images that you can sort of simulate that what you would get if you had this EDOF technology with different clear vision at different distances, etc. Manage the expectations is always important. I mentioned about individualizing again. I've said it many times now. So for me personally, I tend to have more than one IOL choice in each category, and I'll show that a lot of the time I categorize based on, like as I mentioned, monofocal, enhanced monofocal, EDOF, and multifocal. You might have one or a couple of lenses in each category. It's not necessarily just one lens will have to fit all. So we heard about the mention of panoptics, and this is one of the trifocals that I have used. Not used it for a while, but it's one of the first ones I've used. I'm not going to elaborate about the technology because I think Thibault mentioned how the trifocality is achieved. It's all slightly different, but understand that This is a trifocal lens which gives you intermediate, near, distance vision. And of course, the Liberty, I'm not going to elaborate again, but the technology was mentioned by Thibault already, and Harvey is going to go into more detail about all the nuances and all the results from the patients he's used it in. The EDOF is another one, the Vivity. This was the first one they talk about non-diffractive. And again, there's something to do with wavefront. They call it X-wave technology. And the Elon you heard about already, which is also talking about linking the wavefronts. So it's again a non-diffractive. So this is what I have, and I also have an enhanced monofocal. At the moment, I'm still waiting for Medicontur. I think they're going to come up with their own enhanced monofocal, but this is one lens that I think has been around. I think it's around in Taiwan as well. Some of you already used it. And that is one of the lenses I have used in some cases for also some amount of presbyopic correction, but it's more like an enhanced monofocal lens. So this is a case of my own patients, all about 30 to 40 eyes. I think the Liberty I've only started using for a while. About 10 or 12 eyes there. But really, I think the defocus curves help to actually give me some comparison, at least in my hands, what I expect to see. I can see with the trifocal lenses, as you can see with the Panoptix and the Liberty, in orange Panoptix Liberty, you get a nice flat defocus curve, which is what you see when you use a trifocal. You tend to have a nice, rather than those big drops. The Vivity doesn't give you as good reading as an EDOF. I find that the Elon does a bit better, but similar in the sense that it also does not give as good reading as the trifocals. And of course, the EMV is mainly an intermediate lens, and the Claron is a monofocal. So this is something where you don't expect to see much reading or intermediate vision. So the defocus curves helps me in my mind, at least in my practice, how my lenses perform in my hands. And these are patients where I have done bilateral implantations. And I tend to prefer bilateral implantation. I don't mix and match so much. I think there are some of my colleagues that like mix and match, where they mix either one technology with the other, or the same, perhaps same platform, but one monofocal, one multifocal. I tend to believe in bilateral implantations, but that's just me, because I find there's a good summation effect when we do that. Contrast sensitivity, this was just looking at the Elon and the Vivity. I find that it's quite similar. I don't have a monofocal there to compare with, or a trifocal, but I expect the trifocal contrast sensitivity to be worse. And understanding the eye, I talk about understanding the technology, so that was just showing some of the brief outcomes that I got with the different lenses. But understanding the technology, this is a complicated algorithm from ASCRS about dry eyes. I'm not saying that you should follow this, but just recognize that dry eyes is an issue. Now, it's very common. It's something that we all face, and in fact, we all have it now. Perhaps some of you looking at the screen and blinking less now will feel dry as well. But it has an impact on our biometry, patient comfort, and the minimum that we can do is when we look at patients and assess them in clinic is to at least look, lift, pull, and push. So that's really just lifting the eyelid, looking, doing a tear breakup time, paying a little bit more attention to the corneal surface, to the ocular surface, so that you know whether you need to pre-treat them or at least preempt them, that you may not have a perfect outcome if your dry eyes is not managed well. So I don't follow this algorithm. I'm just showing you that there's been a lot of effort, perhaps from the ASCRS side, to actually look at all these things. I don't follow it to the T, but it just gives me an idea about what I should be asking for is symptoms and signs. So ask about symptoms, and you find in dry eyes, the symptoms don't always match the signs. You might have some people that do not show very bad tear breakup time, they're very symptomatic, or some that are very poor tear breakup time, but they're not so symptomatic. So you have to manage the dry eye pre and post-op. So sometimes you find, in my case at least, if I find that they have dry eye, I tend to give them their ocular lubricants, or in some case, to make sure that their dry eyes are well managed. Sometimes you give them supplements, or even do IRPL for them or something, just to make sure their eyes are all ready and prepped before you do even biometry or you operate on them. Because we know that once you operate on these eyes, we worsen their dry eye condition, or we could create more dry eye if we operate when we do cataract surgery. So manage the dry eyes, ideally before biometry. Now, is that possible in all cases? Sometimes, no, because sometimes they come in, they expect everything to be done quickly, so we might do the biometry beforehand. But if you do pick up someone that seems to show very abnormal biometry, or between differences between the two eyes, you may want to repeat them after you treated the dry eyes. But bear that in mind. So using lubricants and really warning the patient and lowering the expectations a little bit when you see dry eyes before you. Some of the other things to rule out, of course, sometimes, I'm guilty of it. I do some retina work as well. Sometimes when I look at a cataract, I see past the cornea, straight to the cataract, and forget that, there's something in between, and looking at the different layers of the cornea, picking up perhaps guttata or some Salzmann changes, etc. And don't forget about their comorbidities like diabetes. The OCT is crucial for looking at the macula. So if you pick these up, then you know that they may not be the best candidates for these kind of, at least not to start with. You'll find that those that have been using these lenses for a while might think that perhaps even the EDOF, some people even use trifocal lenses in these cases, but they are not the ones that I would start off with. So if you're starting on your premium IOL journey, please exclude them. You don't want to start off in these cases. And of course, forget about post-refractive, because the calculation is another whole lecture altogether. Remember the OCT, as I said. Start off with pristine eyes. That's the best way to start. Now, we have a lot of patients with myopia in this country and in this part of the world. So it may not be easy to just try and find a hyperopic patient, so you have to start at some point. But just remember that myopic patients, especially if they're highly myopic, they're a little bit more challenging. And sometimes you want to make sure that you get their near vision first, because they are myopes and they're used to having good near vision. And you'll find that in the higher myopes, sometimes when the distance is not so great, they're still very happy. So the idea is to make sure that in our population where you have a lot of myopia, then you'll have to sort of look at them a little bit more carefully, rather than just always, somebody says just target planar or first minus or something. So you might have to adjust your refractive targeting sometimes. And only with experience do you start venturing into these slightly more complex cases. So what happens to the problem eyes? Why we don't want to do that is usually because there's contrast or light loss, and you might end up with suboptimal vision. And because of the already compromised state of the eye, you really want to avoid light-splitting IOLs. So for me personally, I do not use the diffractive platforms, or usually the trifocals, or even the refractive trifocals, because when you lose more light, then in these cases where they have an ERM or glaucoma, perhaps, they may not get great vision. So an EDOF may be a better option if you really must push for a presbyopic lens. But again, these are problem eyes, which, again, I wouldn't expect that you would start off with, but as you get more experience, you might look into that. I've not had any experience with the pinhole IOL, but the pinhole IOL is something that's available. I'm not sure if it's available in Taiwan. I've heard in Philippines, Bobby talks about it a lot, but I have no experience with that. I think this is just something a bit cliche, really. I think we are always hearing that. I think whether it be related to premium IOLs or just, general medical practice, you tend not to overpromise your patients. We never tell them that we're going to really sort their problems out 100% of the time, and you never tell them you'll never have a complication, because there's nothing absolute in medicine. With medicine, we always know that something can happen, and we really want to avoid such terms when we're talking to the patient. So there's no perfect lens. I would tend to say that this is probably the most suitable lens for you. And I don't want to get rid of your glasses. I might just make it such that you're less dependent on them. You might still need glasses some of the time, depending on what task you are. And you have to talk about complications. And in the case where you do have a PC rent or some problem with the capsule, you might end up with a monofocal lens. So it might not turn out to be an absolute surprise when when the doctor tells, when you have to go and tell the patient that, oops, I had to actually put in a monofocal lens, and you might need glasses after all. So this is really just setting the tone, but you have to do it in a way that it's not going to completely put your patient off. So I think I can't really tell you the art of doing it, but there's some communication skills that you need to actually, be able to explain potential complications without putting the patient off completely. Dysphotopsias I would tend to mention, particularly more if the patient is headed towards a trifocal lens, and whether they're going to be night drivers or whether they're better suited for an EDOF lens, because it's something that we will worry about. So some of the intraoperative things I talked about, preoperative. Now, intraoperative, I think this is just down to our level of experience and how we can continue to monitor and hone our skills. So as I mentioned, we don't want to be facing lots of intraoperative complications. So this is just about learning some techniques. I find very practically, as we actually move along, make sure that we do face, not make sure that we face, but make sure that we are equipped to actually do at least a good anterior vitrectomy when we need to. When we face problems, it's not so much as to some of, I've heard before where, you know, you have a PCR and, you know, your OT nurse doesn't even know where the anterior vitrectomy set is. And that's a problem because you need to be aware, because we cannot expect to do surgery without facing complications. So remember, I think bimanual pars plana vitrectomy is really something that I would advocate, but you know, I might be biased because I'm a retinal surgeon, but it's really not that difficult to put in one of these ports which are readily available. I think one of the advantages is I find that you're always pulling vitreous away from your wound when you're actually doing that. Using triamcinolone is crucial so you can see where the vitreous is, because vitreous is not visible. You can always say that, oh, I've got no vitreous, but the next day you've got a peak pupil, you know, with vitreous at the wound, and that's a problem. So learning how to do anterior vitrectomy is not easy because it's not something that we can get good at because we really don't want to be facing and practicing with that, which means that you're having a high complication rate. But attending courses and, you know, attending all these bigger Asia Pacific or even European or American meetings, they always have these kind of skills transfer courses when you can get hands-on to learn how to do anterior vitrectomy properly. I prefer not to do a limbal. Why? Because when you're actually doing a limbal, you think about it, you're actually pulling vitreous from the back to the front, which really you don't want to. You want to be cutting vitreous off at the back. So I tend to believe that doing a pars plana vitrectomy is advantageous, but really I think that's my biased opinion. I think there's going to be people that argue that limbal is better or limbal is more suitable for the anterior segment surgeon. In any case, I think really learning about anterior vitrectomy, I'm just trying to bring that attention to you that whilst you're going to be embarking on a premium IOL journey, I'd expect that you pay a little bit of attention to potential complication management, and this is just practical. The other thing that I'm going to talk about is dry eyes again, and this is in the post-op scenario. So remember, if you have patients that have got no pre-op dry eye, they could potentially have dry eyes post-op because you have operated on them. So try not to write them off because you have these patients which are seeing well when you check their visual acuity, but they're complaining. They're not that happy, they're feeling a little bit gritty. They might be sitting in your waiting room talking to the patient next to them and say, the doctor did my eye and now I feel like, you know, that the eye is not right. But you have to reassure them. It's a lot of hand-holding and just understanding their problem and trying to correct and manage their expectations. Now, refractive surprise is something that we're seeing a little less of. Well, more and more, it's not so common now. It's why? Because I think we have very good formulas. And when we have good formulas, then you tend to find that you're within target most of the time. But toric IOL rotation is one thing. Perhaps Alison might cover that as well. But when to rotate, and do we actually rotate even when it's a bit off, when the patient is not symptomatic? Those are questions that we need to answer. But just remember that if you do end up with a scenario where you need to rotate, there are certain formulas that you need to use before you decide whether you just put it back to where it was before, or do you actually put it at a different axis to correct, because you have altered the anatomy of the eye once you operate it. You've perhaps induced more astigmatism, so it may not be as simple as just putting it back onto axis. So remember that when you're talking about IOL rotation. Of course, if the patient is not so symptomatic, then you may not need to do anything. Putting glasses may be good enough. A piggyback IOL or maybe perhaps even an add-on IOL is an option. I think Alison will cover that with the add-on lens. And sometimes an IOL exchange is necessary. Now, IOL exchange is not something that we want to do, and I personally, because I've been doing more and more presbyopia lenses, I've had to explant some lenses, even they are seeing well, because of dysphotopsias, or purely because of poor quality of vision, and you can't get it right all the time, but you must at least know that and prepare to actually exchange an IOL as the last option for the patient to sort their problem out. So these are some of the dysphotopsias you can expect, perhaps not to the same extent, but I would like to highlight that, perhaps these are glare and these are halos and starbursts. This is an illustration of what it could be compared to in a normal scenario. And it potentially is unavoidable when you're actually dealing with these presbyopia lenses. So most people, as I've realized, can adapt to them. And the problem is we cannot find out which ones can and which ones cannot. There is no simulator, or at least not one that's widely available for us to use to put the patient in front of and say, okay, we put this lens in and then you're going to see this, are you able to cope? Because if you think about it, they have a cataract in place, and that cataract itself can create some dysphotopsias as well. So it's a bit difficult to really tell them what it's supposed to be like. But sometimes when you get them, you have to recognize that they do have them. You know, the worst thing that a patient can feel is that the doctor keeps telling them everything is fine, but they're not seeing fine. So you have to at least acknowledge that they have a problem and try to handhold them for a while. If there's PCO, you know, the issue to yak cap or not, you know, manage dry eyes, and sometimes you use some drops. And ultimately, if you can't solve their problem, you know, and they've been around the block and seen all your other colleagues around, their competitors, you might want to do an IOL exchange. So doing an IOL exchange is something that, again, there is no real training that you can actually go through, whilst at least not during your residency training. But you tend to pick up techniques, again, for attending meetings, attending workshops, going for skills transfer courses, and you just learn about how to actually do this. And I'm sure some of us here have done enough, and not purely by choice, but because when we do enough of these presbyopic lenses, you're going to have a patient that's not happy. I'm just showing here, this is a patient with a Vivity lens. I had to take it out because he's absolutely unhappy with the vision that he's got, and he's got some dysphotopsia he's not happy about, and he just didn't want the lens after about 3-4 months in the eye. So it's not too difficult when it's doing quite early. You see the lens is not too fibrosed. But you see, one of the things I try to encourage is a bimanual technique. You're always trying to get under the capsule to put viscoelastic to fill the bag. And you tend to use 2 hands to try and get the IOL out of the bag, and it can come out quite easily. So this is a Vivity, it's not an Elon. I've not had to explant an Elon, that's good, right? So you tend to cut it and remove it, and sometimes when you have a large enough wound, you can just pull it out. Some of these lenses will come out of a 2.8 or 3 millimeter wound, but I'm a 2.2 surgeon, but you tend to have to explant them this way. Now these are more difficult explantations the longer you leave them in, and the problem about explantation is you may end up in a situation where you have compromised the whole capsular bag and you can't even put a lens in, and that is one scenario that you have to warn your patient about. So again, not to be the doomsayer to tell you about how bad premium IOLs are, but I'm just trying to highlight some of the practical considerations when you start off that you must be aware that you need to manage these as well. I mentioned this at the beginning already. So the minimum that you can do is to look at your own outcomes, and whether it be your refractive outcomes or your complication rate, but at least have some setup to actually look at how you are doing in terms of your surgical outcomes for your patients. And that's the only way you can be at your best to deliver the best to your patients. So this is just my last slide, really. So a very simple decision tree that I have. And really, I asked the patient, do you mind to have glasses after operation? And I think if they said, I'm okay, I'm used to wearing glasses, I'm happy to wear it continually after operation, I'll just go for a standard monofocal. And if they find that they want to wear reading glasses and they don't want to correct their astigmatism for whatever reason, I think most of the time in my scenario, at least in Malaysia, why they may choose not to correct astigmatism is purely a cost issue. So if they go for, perhaps they want to be more independent from glasses, meaning they want presbyopic correction. So in Malaysia, we have the 3 main races that read either Malay, English, which uses the normal alphabet, or Chinese. And Chinese uses, I think all the Taiwanese here obviously read Chinese, and you can see traditional Chinese has got lots of different characters. And the demand for reading Chinese is a little bit more, and you might find that, you know, they need better near vision. And usually I'll go towards a multifocal, like a trifocal. If they are a bit more concerned about dysphotopsias, or they drive at night, or perhaps they don't mind a little bit of a help with reading glasses, perhaps they just need to read their WhatsApp or Line in this case, and they don't mind wearing reading glasses, then I would give them an EDOF. If they want some freedom from glasses, but they're worried about cost, then I will try to use an enhanced monofocal with a mini monovision approach and tell them that I can give you a better range, but more than likely when you do any prolonged reading, you're going to need some reading glasses anyway. But that is almost a budget presbyopia correction option. So that's my last slide, and I hope I haven't taken too much of your time, but just some things to think about when you want to adopt the premium IOL journey. So look at your own outcomes and look at the eye of the patient and really understand the technology and some of the potential complications you may face and make sure that you're prepared to face them. Any questions, please put them up on the slide. And I'm open to any open questions here. Oh, we have questions. Right, so the first question is asking about the percentage of contracture of the capsular bag after placing a Liberty IOL. Well, I've not placed enough to see any contractions. Have you, Harvey? With your experience with the Liberty IOLs, do you see a lot of capsular contraction? Not really. I think I was wondering why would they expect there to be particularly more capsular contraction in Liberty? Because hydrophilic.
We actually see less. Yeah. With the Liberty, we actually see less posterior capsular opacification compared to other lenses.
Oh, really?
Yes. So we've done a study. We looked at our YAG cap rate, and we find that at 2 years, 20% of our patients undergo YAG capsulotomy. But we looked at our Liberty lenses in particular, and at 2 years, our YAG cap rate is only 5%.
Okay. That's great. Great to hear. I think we'll hear more about that tomorrow. All right, the question next is about chair time. So whether it's the surgeon themselves or is it the staff that's been trained to actually figure out, the lens solution for the patient and provide options. Perhaps I ask, Alison, I mean, in your practice, I think you're refractive cataract surgeon, so who does all this counseling and who determines what lens is best to use?
Look, at this stage I do, because I'm best placed to really decide what the best fit is for the patient. And I think my staff definitely can talk about generalizations in terms of multifocality, the trade-off is dysphotopsia, the option of extended depth of focus, adjusting the outcomes in some way if you're suitable to boost the near vision, so micro monovision or monofocal. And we don't even talk about torics, we just correct it anyway. So I'll talk about that in a few minutes. But really the nitty-gritty of the patient facing, this is what I recommend for you, this option A, option B, these are the pros and cons. If there is more than one option, it comes to me. Yeah.
I think most of us are the same. I think maybe Harvey as well, because perhaps I should ask Alison, how do you get that information? Do you actually spend that time with the patient asking about occupation, or do you have some flow along the way to pick up?
So I have a lifestyle questionnaire that every patient fills in on intake. So at least I know what their expectations are. And it lists, near, intermediate and distance type tasks, and where on the scale of 1 to 5 they are seeking, I don't mind wearing glasses, to I hope to be spectacle independent. And then over time I've refined that further, and I have a further question, which is not all patients are suitable for increased independence for all tasks. So would you prefer to prioritize the distance or the near? And so that really helps me. And on that lifestyle questionnaire, I also ask them to list hobbies. There are a few tick boxes with more common scenarios, including night driving. Yeah.
I think that's what you find. I think, we try to refine our practices to make it efficient because, we have 50 patients sitting in the room, and if we are spending half an hour with each one, then you don't have to go home, right? You've got no life. So how do we run a practice where we can deliver this kind of technology and not having to kill ourselves doing it, because you're going to spend 30 minutes talking to every patient, finding out about, all their hobbies. So that's something that I do as well, but I don't have a questionnaire as such. I think I find that, every practice is different. I don't think a lifestyle questionnaire may be applicable to everyone's practice, even in Taiwan. perhaps in my setting in Malaysia, I find that some of the patients can be illiterate. So when they are and they still want to be free from glasses, and there's nobody there to help them fill in the questionnaire, and they don't always have a member of staff that's free to do that for them. So it doesn't work all the time. But what happens is when my patients go through the, as you know, when the patient comes in, they have visual acuity checking, they might have air puff tonometry or eye-cat tonometry along the way. So I have my patients, rather my staff that's trained to ask some questions along the way. So they then fill it into the medical record, and when it comes to my room, I get the information there. So that sort of helps to shorten my chair time with the patient, but it's just about what works for you in your practice. But the main thing is to find out what kind of information you need. Sorry. Anything else to add? Anybody? No? Right. Okay, this one I think maybe Thibaut or maybe not so much Nikki. So will there be a hydrophobic liberty coming up soon? Work in progress, okay. So there you go. I think manufacturing the hydrophilic and hydrophobic lens is quite different, I think. So there are some challenges, yeah. That's right, yeah. So work in progress. Right, so what would you aim if going to put second eye for Elon lens, assuming first eye is ametropic? I think that one is a question that can be answered in different ways, depending on what your patient requires. So I think if it's an Elon lens, so if you have a patient that perhaps needs a little bit more reading, and I think we were just talking about this earlier at lunch, so there can be a bit more of a process of finding out a little bit more what the patient can tolerate, how much anisometropia they can tolerate. So, I personally tend to, I'll present the data tomorrow, I tend to have an average of offsetting about half to three quarters of a diopter for the non-dominant eye that tries to pull in a bit more reading for them. But even then, I will never promise them very, very good reading, because that's not the category of patients that they should be in for me to use an Elon lens anyway. But I tend to offset somewhere between half or three quarters. I think perhaps some people have gone up to about a diopter. And that's what I would tend to do. Yes, Harvey, please.
So what ocular comorbidities would you consider using the EDOF lens?
Right, okay, so EDOF lens and comorbidities. I think for those of us that are starting out with multifocal or premium IOLs, I would say none. So as you're starting off in your first maybe 10, even 20 patients, you want those pristine eyes, and perhaps, you can't get away from completely no dry eye, maybe a little bit of dry eye is okay. Now, when you come to comorbidities, I think in my cases, what I've used it for is mild, moderate glaucoma, if you can call it that, where they have maybe one eye drop and under control. You look at the visual field, it's not very bad. Your mean deviation is still quite good, and they haven't got a very advanced glaucoma because you're going to have loss of contrast. Now, from a retinal surgeon's perspective, then I will look at, macular holes are out, epiretinal membranes, when you do an OCT, and can you see a little bit of a membrane where there's not too much distortion of the architecture of the fovea, I think it's still okay. So I think I go up to that level. I'm not too adventurous from that point of view. Do you have enough time, Nikki, to move on, or should we move on? Yeah. I think we have some extra time at the end to talk about more questions. But we want to hear from Alison next, because she's going to talk to us about adopting toric technology, and no better person, because we know Australia is the toric capital of the world. So they correct astigmatism for everybody. So Alison, please. Thank you very much.